Well, good morning to everyone attending in person here at the meeting in St. Louis, and good morning to everyone that's attending the meeting virtually online. I am Patrick Gonzales. I am from the Cytogenetics and Molecular Oncology Labs at the University of Kansas Medical Center in Kansas City, Kansas. On behalf of the Cancer Genomics Consortium and the CGC 2022 Program Committee, it is my distinct pleasure to introduce our keynote speaker this morning, Dr. Bruce Korff from the University of Alabama at Birmingham, a man who wears many hats, voluminous list here. He's the Associate Dean for Genomic Medicine at the UAB School of Medicine, the Chief Genomics Officer of UAB Medicine, the Wayne H. and Sarah Cruz Finley Endowed Chair in Medical Genetics, Professor of Genetics, Co-Director of the UAB Hudson Alpha Center for Genomic Medicine, the Associate Director for Rare Diseases of the Hugh Call Personalized Medicine Institute, and Editor-in-Chief of the American Journal of Human Genetics. Bruce Korff is the past president of the Association of Professors of Human and Medical Genetics. He's a past president of the American College of Medical Genetics and Genomics. He's the current president of the ACMG Foundation for Genetic and Genomic Medicine, has served on the board of scientific counselors of the National Cancer Institute and the National Human Genome Research Institute at the NIH. Major research interests are genomic medicine and the natural history, genetics, and treatment of neurofibromatosis 1. He serves as the principal investigator of the Department of Defense-funded Neurofibromatosis Clinical Trials Consortium and is the co-PI of the Alabama Genomic Health Initiative and the All of Us Southern Network. He is the co-author of a medical student textbook, Human Genetics and Genomics, now in its 4th edition, as well as Emery and Remoyne's Principles and Practice of Medical Genetics. So please join me in welcoming Dr. Bruce Korff. Bruce, you have the floor. So there's to advance, here's to rewind, and here's laser.
Excellent, thank you. Patrick, thank you, and thanks very much for including me in this meeting. Reminder, I was once introduced as wearing multiple hats, and the introducer said there was a lot of hats for a small head. All right, I'm going to speak to you this morning about a condition that I've been studying, well, now for 39 years. The anniversary of the NF clinic I started in Boston will be just in a matter of days. Here are my disclosures. So I'm going to focus today on neurofibromatosis type 1, but just to establish the nomenclature, there are 3 forms of neurofibromatosis that are genetically distinct. We'll talk in detail about NF1, shown at the left, and the responsible gene is on chromosome 17. NF2 is a distinct disorder characterized by bilateral vestibular schwannomas, as well as a number of other tumors, but distinct from the neurofibromas of NF1, the gene NF2 on chromosome 22, and schwannomatosis, a condition where schwannomas are the hallmark feature, and the genetics of that are complex. I won't go into detail about it now. These are all under the umbrella of the neurofibromatoses, largely because, well, they're nerve sheath tumors at the basis of each of them, and for many years, historically, these were difficult to distinguish, but we now know they're quite separate disorders. A few just kind of facts and figures here. NF1 affects about 1 in 3,000 people around the world. There don't seem to be any particular hot spots. That frequency is quite constant. It's a dominantly transmitted disorder with complete penetrance, but highly variable expression, and about half of cases are due to new mutations, which probably explains why the frequency is what it is. And just mentioned the genes on chromosome 17, it's a tumor suppressor gene. The protein has been named neurofibromin. And this is a very kind of protein disorder that changes over a person's lifetime and varies from person to person, even in the same family. Being from Alabama, this is a graphic of if you could bring all of the people in the United States affected by NF1, this is what it would look like. And it just gives you a sense of the scale of this disorder. Well, NF1 is a clinical diagnosis. The diagnostic criteria are listed here. two or more features on this list for a person who does not have an affected parent would establish the diagnosis. These have been in place now for well over 30 years and mostly have stood the test of time. The two areas that are shown in red, the presence of choroidal abnormalities and the existence of a pathogenic non-mosaic NF1 variant, those are new additions to the diagnostic criteria just in the past year or so. Just walk you through a few of the signs. Pigmentary signs are usually how this begins. Cafe au lait spots shown at the left, more than 6, bigger than 5 millimeters before puberty. These are actually melanocytic clones, and we'll see later on a little bit more about what goes on at the molecular level. And then skin fold freckling, usually between about 3 and 5 years of age. And these two would actually establish a diagnosis other than for another condition called Legius syndrome, which is due to mutation in a different gene, but also in the RAS signaling pathway, also produces cafe au lait spots and skin fold freckles. Well, the defining feature is the neurofibroma, and here are some shots of what these can look like. They usually begin to appear after puberty, although with care you can sometimes see them in younger children. They can be pedunculated, and as you can see, they can be exceedingly numerous, and we'll talk in just a little while about what is going on at the molecular level in the production of these cutaneous neurofibromas. They occur in most adults with NF1. As you can imagine, they're quite disfiguring. They can itch. They can present hygiene problems, but they do not transform towards malignancy. Now, the other major kind of neurofibroma is the plexiform tumor, shown here in a variety of shots. So you can see that in the upper left, there's a plexiform tumor of the upper eyelid, which can extend back into the orbit and cause the eye to bulge forward. Very difficult to treat. Surgically, it's impossible to remove these. To the right, the child with the enlarged arm shows you the soft tissue hypertrophy, invasion of the skin. And maybe you can notice this sort of speckled hyperpigmentation that overlies that lesion. On the lower left, you can see a close-up MRI with the so-called target sign. I don't know if I'll be good at using this. I'm not sure how this pointer actually works since, well,
Yeah, just hold it like this.
yeah, but where I'm pointing, I can't really. All right, well, anyway, the target sign, I guess you can see right here. This dark interior and then the bright exterior defines a plexiform neurofibroma. Just below it, to the right, you can see an example where multiple cervical nerve roots are affected down into the mediastinum. And then the two pictures to the right, again, show the cutaneous hyperpigmentation and invasion of the skin. These can be disfiguring. They can cause pressure on the airway, on the spine, and can also be a precursor to malignancy, a point we'll come back to later. If you look at the pattern of growth, so you're looking here at percent change on the y-axis and age on the x-axis, you can see that the majority of growth occurs in younger children. Plexiform neurofibromas, we believe, are usually congenital, that then they begin to grow in the early years of life, and most of the time that growth stabilizes, with the exception of some instances where malignant change might occur. Among the ocular manifestations, Lisch nodules, shown at the left, melanocytic hamartomas on the iris, harmless to vision, useful as a diagnostic marker, and then the recent addition of choroidal abnormalities, also typically asymptomatic. Not so asymptomatic in many are optic gliomas. They can occur at the optic chiasm, shown at the left, or the optic nerves, or any combination of these, and they're not rare in NF1. About 15% of children will show sign of optic glioma by imaging. If they're going to progress, they usually do it in the early years of life, I'd say by about age 6. Most of them remain asymptomatic, do not affect vision, but some will cause visual dysfunction, progress, and also can cause precocious puberty because of their nearby hypothalamus. And we only treat lesions that are symptomatic, and there really is not much practical molecular genetics of optic gliomas because they're virtually never biopsied. It's obvious what these are from imaging in children with NF1, and when they're found, they're followed, although consensus guidelines argue against doing routine screening imaging, and so we typically rely on routine ophthalmologic exams and then would embark on treatment only if there's progressive loss of vision, and there can actually be radiographic progression totally in the absence of any signs or symptoms. Skeletal dysplasia, a non-tumor manifestation shown in the upper left, bowing of the leg. The x-rays at the right are from the same child, and you can see bowing of the tibia and fibula here. When that happens, the bone is fragile, prone to fracture, and if it does, it can be exceedingly difficult to treat. There can be a very sharply angulated scoliosis. Sometimes there'll be a plexiform neurofibroma at the apex, sometimes not. And the skull base, which is shown at the right, illustrates, I don't know if I can point to it, right there, a defect in the greater wing of the sphenoid, often, though not always, associated with plexiform neurofibroma of the orbit. There, by the way, is also a generalized decrease in bone mineral density and sometimes a vitamin D deficiency for unknown reasons. Very common manifestation is neurocognitive. At least 50% of children with NF1 experience some degree of learning disability, attention deficit disorder, sometimes autism spectrum disorders, and then a small subset will have significant reduction of IQ. The IQ curve shown here is mostly the orange, I guess, from data from Kathy North and an NF population in Australia. Superimposed in yellow are a few examples of patients with very large gene deletions that I'll come back to in a few minutes, but they tend to have significant cognitive dysfunction. Vascular complications can occur, including occasionally cardiovascular malformations. Hypertension, particularly due to renal artery stenosis, can occur in younger children. Pheochromocytoma, tumor of the adrenal, is another potential source of hypertension. Usually, though, when it occurs, it's essential hypertension. And then there's a cerebral vasculopathy that can lead to Moya-Moya syndrome, occlusion of the internal carotid, formation of collateral vessels, and potentially a risk of stroke. It can occur sporadically in NF1. In the days, which are now bygone, of treatment of optic gliomas with radiation, all of those individuals develop Moya-Moya, more or less. And then there can also be instances of hemorrhage due to a proliferation of cells in the inner arterial wall that weakens the wall, can ultimately lead to dissection. Malignancy is probably the most feared complication. 8 to 13% develop a malignant peripheral nerve sheath tumor. It can be diagnosed usually by the onset of unexplained, persistent, severe pain, the kind of pain that wakes you from sleep. Fluorodeoxyglucose PET imaging can be used to demonstrate in the right leg in this individual, your left, his right. You can see that large tumor. There is an increased risk of breast cancer in women, and as a consequence, it's recommended to do breast cancer screening beginning at age 30. There's an increased risk, as I mentioned, in gliomas, not only the 15% of children with what turn out to be pilocytic astrocytomas in the optic pathway, but other gliomas that can occur at any age, gastrointestinal stromal tumors, and I mentioned pheochromocytoma. And by the way, the prognosis of MPNST and NF1 is pretty dismal. You can see the Kaplan-Meier curve there in the center, and the left-hand curve are MPNSTs and NF1, which have a worse prognosis than their counterparts in the general population. Hard to know if that's biological or if that has to do with delay in diagnosis. Most people, if they develop a tumor, it's going to be investigated pretty promptly. In people with NF1, that's really not practical because they're pretty much always developing tumors. And so there's probably a delay in recognition of a particular mass as being malignant. A few other things quickly to mention. Short stature is common in children with NF1. They tend to have a large head size relative to their body size. There is an increased risk of seizures, usually not associated with a mass lesion. They can get headaches that appear to be migraines mostly. Glomus tumors, tumors of the nail beds, can cause excruciating pain in the fingers and toes, and a lot of people don't recognize that as a component of NF1, but it's an important one because it's treatable. And juvenile xanthogranuloma can occur in the early years of life. It's a benign feature that seems to self-resolve. If you look at life expectancy in NF1, it is shifted downwards, although the range is still within a more or less normal range. And usually the NF1-related causes of death are the MPNSTs, other kinds of tumors, including gliomas, and then the vascular problems I mentioned earlier, particularly the risk of arterial dissection that can cause catastrophic hemorrhage. Well, NF1 is a classic dominant disorder with complete penetrance. It never skips generations, but highly variable expression. And about half of cases, as mentioned, are due to new mutation, where you can identify a pathogenic variant in a child, and you'll find no signs or symptoms in the parents, and on testing, also no evidence of a germline mutation. Of course, there is the possibility of gonadal mosaicism, and that does occur, but it's actually fairly rare. So unaffected parents of a sporadically affected child have a low, not zero, but low risk of recurrence, nothing like the 50% that would be the case if one of the parents was affected. If you look at the mutation spectrum among germline mutations in NF1, it is exceedingly diverse. Ludwig Messiaen, recently retired, ran the UAB Medical Genomics Lab for almost 20 years, and you can see the diagram to the right showing the gene, which is the gray horizontal bar, and then the stars below it are pathogenic variants, small mutations, and this is, as you can see, from 2007, it reached a point where the mutations were too numerous to fit on a single image, but the quality of this hasn't changed very much, and although the quantity has, there something over 3,000 distinct proven pathogenic variants in the NF1 gene. Anyway, all these small mutations shown at the bottom, the vertical lettering indicates splicing mutations, and then the purple bars are deletions. So the mutations are exceedingly diverse, and if you look at the pie chart of the types of mutations, most of the mutations are loss-of-function mutations, nonsense mutations, frame shifts, copy number changes. About, in this slide, 18% are missense, that is amino acid substitutions, and then a small subset of whole gene deletions. Anyway, the majority of these are loss-of-function mutations, a point we'll come back to in a moment when we look at pathogenesis. There are some, not that many genotype-phenotype correlations. The large deletions are known to be associated with a particularly severe phenotype. There are a few other specific mutations, I don't think I'll go through every one of these here, where phenotype differences have been found. There's one 3-base deletion that deletes a methionine that seems to be associated, on the other hand, with an exceedingly mild presentation, mostly pigmentary, without major signs of tumors. Here's an example of an NF1 gene deletion. It's probably been a while since you've looked at a fish picture, but it shows graphically here the NF1 gene labeled in red and green, and then a marker for chromosome 17 in green, and you can see the upper left completely missing the NF1 gene. These deletions are usually about 1.4 to 1.5 megabases and include multiple surrounding genes. They produce an early onset of a large burden of cutaneous and other neurofibromas, plexiforms included, and those are the individuals on the far left of the IQ curve. They tend to have intellectual disability, increased risk of seizures, and then most notably, a probably doubling of the risk of malignant peripheral nerve sheath tumor. There's an entity that has been, I think, somewhat erroneously labeled spinal NF, called that because every single nerve root in the spine will be enlarged, but not only that, but you can see here, the radiograph shows an MRI of the legs, and you're looking at the sciatic nerves in this individual. They're obviously massively enlarged, and that's true of virtually every major nerve in the body. This particular person had a deep intron mutation, and in fact, most of the spinal NF are either missense variants or splicing variants and don't usually produce a huge burden of cutaneous tumors. You may be able to discern on the back that there's this pebbly appearance under the skin where there'll be enlargement of nerves, but usually not much, if any, of the cutaneous tumors. We do see mosaicism in individuals with NF1. Sometimes it's more or less obvious because there'll be segmental distribution of signs, particularly, for example, cafe au lait macules and skin fold freckles on one arm and nowhere else, or sometimes sort of patchwork of pigmentary signs or neurofibromas. It is possible to culture Schwann cells from the tumors and then to grow them either with or without forskolin, which is a Schwann cell mitogen, and in the absence of forskolin, only homozygously mutated cells will grow, and through that you can identify both what are actually first and second hits in the NF1 gene. And if you culture melanocytes from a cafe au lait macule, you will also see a germline mutation and then an acquired second hit. And I'll show you an example of that in just a moment. These days, NF1 is included on many cancer panels, for example, breast cancer panels, and it's not so unusual for us to see individuals in clinic who had never previously been diagnosed with NF1, who present because they were found to have an NF1 mutation on a cancer panel done because of a personal or family history of cancer of some form. And there's various explanations for this. Some of them actually have NF1 and just never got formally diagnosed, and for whatever reason they hadn't really questioned, but sure enough you'll see neurofibromas and cafe au lait spots and so on. Some of these individuals are mosaics. They turn out to have a kind of not necessarily segmental distribution, but just a relative amelioration of the phenotype. Sometimes they have an underlying tumor, particularly a leukemia, which includes an acquired NF1 mutation. And although I don't think it's been proved, I think clonal hematopoiesis may also be a potential explanation in some of these individuals. Well, NF1 does function as a tumor suppressor. If you look at the Schwann cells as a precursor, they would be heterozygous because of the germline mutation. But then if you look at neurofibromas, which we will in just a moment, you'll see that there is biallelic loss of NF1. And then there's also signaling of other cells in the periphery that leads to the bulk of the neurofibroma. And I'll show you a bit more about that. And it's the acquisition of additional changes that ultimately leads to malignant peripheral nerve sheath tumor. Here's a person that we saw a while ago now with a patch of neurofibromas you can see on her neck with no other signs of NF1 anywhere. And we're able to biopsy 10 of these neurofibromas. In 9 of them, it was possible to grow Schwann cells from the tumors. And what was found ultimately was a multiple, first of all, a 2.5 megabase microdeletion that all of these neurofibromas shared. But then each one of these neurofibromas, even though they're clustered in a very small space, had a distinct and separate second hit in the NF1 gene. And there's no pattern to these either. Deletions, point mutations, all sorts of different variants were seen. And it's a pretty amazing thing when you think about it. So if you extrapolate this to what we see on a person that has millions of cutaneous neurofibromas, to realize each one of them is a separate and distinct second hit. Now, if you look at the progression of these from benign neurofibromas toward malignancy, this is a slide pulled from a paper by Aaron Kim and others. You can see that if you look at the cutaneous neurofibromas or the plexiforms, they actually don't really look any different through the microscope. The histology is very similar. And all you see is loss of NF1, and that's it. They are pretty monotonous otherwise from a molecular point of view. They don't tend to include other gene mutations, and they grow as benign growths. Now, there is an entity referred to as a typical neurofibroma, and these tend to be relatively spherical, somewhat homogeneous masses that are now believed to be a precursor to malignancy. And these have loss of NF1 and, in addition, CDKN2A variants. And then malignant peripheral nerve sheath tumors, which are not easy to distinguish from atypical neurofibromas radiographically, you can see in the middle panel, tend to have an acquisition of multiple other variants, a few of which are shown here on the slide, TP53, PRC2. They also tend to have large burden of copy number changes. There's a paper from the Genomics of Malignant Peripheral Nerve Sheath Tumor, or GEM consortium on bioRxiv now, that demonstrates very large burden of copy number changes. Looking more carefully at either plexiform or cutaneous neurofibromas, they're very heterogeneous from a cellular point of view. They include Schwann cells that we believe are the underlying tumor cell, but they include many other types of cells, fibroblasts, mast cells, a variety of immune cells as well. Interesting paper that I had nothing to do with, but which was published in the last year or so, showed little nests of cells that you could find in the skin that was apparently free of at least visible neurofibromas, usually along with adnexal tissues like hair follicles and sweat glands, and with C-fiber nerves associated with these. And these are believed to be the precursor to cutaneous neurofibromas. It has not been looked at to see if these have already lost function of the NF1 second allele. Really interesting question, I think, that needs to be looked at, because the question could be asked, do these occur first as a hyperproliferative state with then the acquisition of the second hit causing kind of blossoming of the tumor, or has that already occurred at the time when these little nests are formed? And then this is pulled from a paper from Nancy Ratner's group, and the main point here, not to go into huge detail, is that if you look at the progression of neurofibromas, what you see is an invasion of multiple cell types, particularly mast cells, macrophages, dendritic cells, and T cells. And so the final tumor that you can see at the far right is a very complex sort of environment that does include the minus Schwann cells, NF1 but many other heterozygous, because of the germline mutation, cell types. I think of a neurofibroma not as a clonal proliferation, but as sort of a city of many different kinds of cells, which raises interesting questions in terms of how to treat them. And then actually a paper from here at Washington University from David Gutman's group. Won't go into details here except to say that they have evidence that the nerve itself is an important component of the tumor, not just a bystander, that is important in helping to sustain and progress the neurofibroma. Well, if you look at the function of neurofibromin, it is a GTPase activating protein, and its target is one of the various isoforms of RAS. When a receptor tyrosine kinase binds a ligand, it leads to GTP binding to RAS, which then signals down multiple pathways towards cell growth and proliferation. And then neurofibromin is one of the proteins that stimulates an intrinsic GTPase activity in RAS that terminates that signal. So it isn't hard to imagine that loss of function of neurofibromin could lead to promiscuous signaling and hence abnormal cell proliferation. Here's a more simplified cartoon of the same thing. And over the years, actually, the Children's Tumor Foundation had supported a preclinical consortium looking at mouse models and ultimately testing drugs. And what emerged from that, to make a very long story short, is that MEK inhibitors were effective in reducing the growth of plexiform neurofibromas in these animal models. And there are several examples of MEK inhibitors that are produced by various pharmaceutical companies because of the interest of the RAS signaling pathway in cancer in general. So a few years back then, and at the National Cancer Institute, Brigitte Wiedemann and her group did a phase 1 trial using selumetinib, one of those MEK inhibitors, in children with NF1 and growing plexiform neurofibromas. And it was twice daily dosing, as you can see. They looked at 24 individuals, and found a maximally tolerated dose and defined some of the dose-limiting toxicities, but the most dramatic thing is shown in the waterfall plot, which is that over 70% of the individuals treated experienced a 20% or better reduction in plexiform neurofibroma volume as measured by volumetric MRI, a dramatic result that then led to a phase 2 trial that was a very similar kind of dosing and led to a finding that validated this, that they found a partial response in 74% and a durable partial response lasting more than a year in over 50%. And you can see here, again, the waterfall plot. Now, it takes time to see this effect, I should say. The volumetric change may not occur between 6 and 12 months sometimes after initiation of treatment, although other symptoms, and I think here it shows some of the other ones that were explored, like pain, for example, or limitation of mobility, have improved a lot more quickly than volumetric changes. Actually, the patient on the right is a patient of mine who I think is maybe the most or one of the two most robust responders. And we were watching a tumor, which you may be able to discern in his right neck, grow over a course of a few years, and the growth curve at the right shows you in black how the tumor was progressively increasing, and it was alarming because it was compressing the airway, and so there was already discussion about whether he would need a tracheostomy, and we're able to get him onto this clinical trial, and you can see where the red begins is after he was treated, and there was a progressive decline in the volume of the tumor. And this is actually a set of pictures that are a few years old now. He's been on treatment, I think 6, 7, 8 years, something like that. And now you have to know where to look to find the tumor. It's still there, but it has shrunk to the point where it's really not noticeable on a day-to-day basis. And there's no concern at this point about his airway. And so this has been a very impressive kind of change for the better in his quality of life. And the side effects have been pretty tolerable. There tend to be skin rashes, acneiform rashes, nail bed infections. There is a risk of visual problems and decreased left ventricular ejection fraction. These are things that are monitored closely and have, at least for him so far, not been a big issue. Of course, the big question is how long will he need to be treated? Here's an example, not from him, of another instance where treatment had to be suspended because of a cardiac output issue. And you can see that after the treatment was started, there was a pretty rapid reduction in tumor volume. And then because of this left ventricular ejection fraction decrease, the treatment had to be suspended, and the tumor grew right back. In fact, to where you might have extrapolated it would have gone if he hadn't been treated in the first place. Then was able to be started back on treatment, and the tumor once again responded. So it really raises the question, is this a lifetime of treatment that we're going to be looking at, or could there be a point, since naturally plexiform neurofibroma often stop growing in later childhood, where no longer will treatment be necessary? And the answer is we just don't know. We're not brave enough right now to take somebody who's been tolerating the drug and experienced a significant reduction in tumor volume to take them off the treatment. Another question that I imagine would be on many minds here is, are there genetic predictors of who will respond? Since not everybody, 70% is pretty good, but 30% don't respond. And the answer is we don't know. There is a study looking at germline mutations. We don't usually get biopsies of plexiform neurofibromas, so it's not easy to look at these from the perspective of tumor genomics, although there is a clinical trial that is contemplated where that may end up being done. So this resulted in FDA approval of selumetinib for treatment of plexiform neurofibromas in children about now a little bit more than 2 years ago, and it has for sure been a game changer in terms of how we manage these. We do think carefully about who we should treat. Is the tumor progressive, which they aren't always? Is this a person in the age range where the drug is approved? Is there morbidity, pain, disfigurement, functional problems, or is it likely there would be if the tumor were to continue to grow? Oftentimes, tumors are stable, not causing major symptoms, and we just keep watching them. And then if there is need for treatment, we ask still, is it possible to surgically resect these without significant morbidity? Is it just one or multiple surgical procedures needed? Is there potentially a clinical trial, about which I'll say more in a minute? And are there concerns about the ability to continue with treatment? And is this an urgent need for treatment? If you have compression of the airway today, and it could take 6 to 12 months for the tumor to shrink, you just can't afford to wait that long. And some surgical decompression is then necessary and definitely benefits from a multidisciplinary team. Well, for the last now 15 years, the Department of Defense has funded the NF Clinical Trials Consortium, which I serve as principal investigator of. And you can see the many trials that the consortium has done, sometimes in collaboration with other groups, shown below the timeline. And many of these, or most of these, done specifically within the consortium. We just learned that will be funded for another 10 years, actually, this time, by the DoD, and have multiple additional clinical trials in the pipeline. I'll just show you a few quick examples. This is another MEK inhibitor, mirdametinib, and the schema for the clinical trials have been pretty similar. Multiple courses of treatment with clinical evaluations done between courses, as well as MRIs, and all the same volumetric MRIs as I showed you in the selumetinib trial, in fact, done by the same group at the NCI, as an endpoint with a partial response defined as 20% reduction of volume. This waterfall plot shows a less impressive response than on selumetinib, and it's hard to know whether that's because of a difference in the drug and its effectiveness, or there were differences in the population treated, and so this trial included some individuals who might have been older than the ones on the original trial. So at the moment, we aren't sure what exactly explains that different response. Also, numbers are small, and it just takes 1 or 2 people who are particularly robust responders to shift things one direction or the other. Another trial of a mixed tyrosine kinase inhibitor, cabozantinib, is very similar clinical trial design. And here again, the waterfall plot shows a partial response in 42% fewer than in the case of selumetinib, but still a meaningful response. And it has led to interest in a combined trial of cabozantinib and selumetinib, which is under study now by the NF Clinical Trials Consortium. I haven't talked much about the treatment of glioma. As I mentioned earlier, most of the optic gliomas don't need to be treated at all, just watched, and occasionally, if they're progressive and signs and symptoms occur, vincristine and carboplatin has been the mainstay, and incidentally, you virtually never get biopsies of these either, so we don't have a lot of data about predictors at the molecular level. But here's a trial for progressive optic gliomas that had failed the vincristine carboplatin using everolimus, because there is increased mTOR signaling seen in tumors associated with NF1, and it did show partial responses in a number of individuals. And there are additional trials I won't go into, some of them conducted by Pediatric Neuro-Oncology Consortium looking at MEK inhibitors in this context. Now, if you think in terms of, how could you imagine treating NF1? There are a variety of different approaches that could come up. As mentioned earlier, we believe this begins as a heterozygous NF1 variant, that then there's loss of the other allele leading to biallelic loss, which leads to increased RAS signaling, and then increased intercellular signaling, which culminates in the neurofibroma, specifically to that kind of tumor. So what could you imagine doing? Well, maybe you could prevent the acquisition of the second hit. Not easy for me to imagine exactly how that could be accomplished, although mentioned earlier, we don't know yet when exactly the second hit really occurs and whether these cells are hyperproliferative to begin with because of the heterozygous loss, and that in turn predisposes them to the acquisition of a second hit. There may be opportunities for treatment at a very early stage to prevent that event from ever happening. If it were to happen, then you could imagine that there could be ways to either restore function to the mutated gene or gene product that would lead the cell to no longer be deficient in neurofibromin. Inhibiting RAS signaling, well, that's what we've talked about for the last few minutes through the MEK inhibitors particularly, and inhibiting intercellular signaling, which I think to some extent maybe how cabozantinib is working, is another possibility. Our group at UAB has been interested in the option of inhibition, or rather the restoration of function to the mutated gene or gene product. I won't go into a lot of detail here, but just quickly mention that this is the same pie chart you looked at a little while ago of the spectrum of mutations. And the group has been creating mouse models, particularly Bob Kesterson and his group at UAB, to mimic human mutations in a mouse. And so we have a variety of missense variants that tend not to produce that visible a phenotype, interestingly, in the mouse, in spite of the dramatic tumor burden that you see in humans. And here, the interest is in identifying either correctors that prevent degradation, because that's what we see, is that these missense variants render the protein, in most cases, unstable, or potentiators to take what may still be partially functional proteins and improve function. So Deanne Wallace and the group has been looking at drug discovery in the context of missense variants. We have actually several. This shows one example of a mouse model of a nonsense mutation, a chain-terminating mutation. And in this case, the interest has been in looking at nonsense read-through. As you may be aware, aminoglycoside antibiotics, for example, can cause read-through of stop mutations. And now the question is, can we identify a set of drugs that would accomplish this in the context of NF1 variants? The specific base sequence around the variant seems to determine sensitivity to some of the various drugs. David Bedwell at UAB, who actually kind of originated the concept of nonsense read-through, has been searching for and found some active compounds, and these are being put in the mouse models to see if we can correct, at least partially, those variants. There are some frame shifts, not easy to imagine how you could fix those. One possibility would be to cause exon skipping if the exon is dispensable. I won't go into this, but Andre Lyer in our group has looked at the question of are there exons that are dispensable in the NF1 gene? The answer is there are. There are not many. That's defined in terms of whether there has ever been a mutation found in a particular exon that causes NF1, and there are just a couple where that's not the case. And then also whether skipping the exon would lead the protein to be in frame or out of frame. There are a few examples where this can be accomplished, but not so many. And then splice mutations, which are fairly prevalent, as you can see. And Deanne Wallace published a paper recently looking at a particular instance of a cryptic splice, I think it was splice donor, that they were able to develop an oligonucleotide to inhibit it, and they could achieve correction of that abnormal splice. We see a lot of mutations that are at the splice donor or acceptor, and it's a little more difficult to imagine exactly how those can be corrected, although the possibility of identifying small molecules that alter the splicing process is something that we're exploring. And then for any of these, the possibility of either DNA or RNA editing or even gene replacement is being looked at. Bob Kesterson has been working with a group at Yale to develop a nanoparticle delivery system, either for CRISPR-Cas9 to aim to correct the mutation, or now they have developed this also for delivery of a cDNA that includes the GTPase activating protein domain, and actually in a rat model that they've developed, which tends to develop mammary tumors, to actually show that they can in part correct those or get those tumors to shrink using a nanoparticle delivery system for a cDNA. Well, with all this, one can ask, where is it all going? What can one imagine as the future of NF care? And I would highlight three things that I think are important sort of opportunities for the future. The first is what referred to here as smart surveillance. Right now, there are consensus guidelines for how to follow a person with NF1, which really pretty much one size fits all because we don't have a lot of data to justify any other approach to surveillance. Can we tailor it to the individual? Now, maybe to some extent that can be accomplished by looking at the underlying genomics. Well, of the 3,000 different pathogenic variants, there's only a handful, actually, that predict anything about the specific manifestations, but there are some. And it's possible as we look more carefully, we'll find others, although most are just loss of function variants, and it's not quite clear to what extent there will be ability to discriminate outcomes there. For a long time, been of interest to identify genetic modifiers. Are there genes in the background of individuals that predict who will develop a larger or smaller burden of tumors, for example, who would be at risk for optic glioma, or who would be at special risk for malignant peripheral nerve sheath tumor. It's not an easy thing to test, it turns out, because although the genomic sequencing capability is pretty robust, the phenotyping is much more difficult. So if you, for example, are trying to look at a modifier that determines who will get a larger or smaller number of cutaneous neurofibromas, that's a dynamic process. These neurofibromas don't usually begin until puberty. Women notice them during pregnancy, so we think maybe there are hormonal influences on tumor development, but you can't compare two individuals at a different age or different history in terms, say, of pregnancies for women and say, well, this person has a smaller burden and this person has a larger burden, because you don't know whether the one with the smaller burden will eventually develop a larger number. So it's been a lot trickier than you might imagine to identify genetic modifiers. But I think there is hope, and there are people working on this now. And then there may be other ways of predicting. For example, there's some data that suggests that if you're going to get an optic glioma, it's going to happen in the first few years of life. And although we don't do routine imaging, maybe we will reach a point where we will, because we might be able to say that a child who, say, is 2 years of age and hasn't yet developed an optic glioma is really not at risk and doesn't need to have annual eye exams, which is currently what we do. And although you might say, what's the big deal? An annual eye exam isn't so hard. In fact, if you're the parent of a child and you're constantly sort of making an appointment or wondering what's going to happen at the appointment, it would be a significant improvement of quality of life if we could define who's really at risk. So I hope over time we'll move towards this kind of customizing the surveillance to the particular individual, and increasingly targeted treatment. The MEK inhibitors are not the answer to NF1. They are the first step towards answers, and it certainly has really changed our way of thinking about plexiform neurofibromas. But the tumors do not completely go away. Not everybody responds, and we do have evidence that the tumor will grow back if the treatment is held. So there's plenty more to be done here, and hopefully we'll be able to reach a point where we can customize treatment to the particular profile of that tumor and that individual. And you can even imagine moving towards a sort of patient avatar system with organoid models that will determine the particular sensitivity of a tumor in an individual and ultimately choice of treatment. And then finally, I think community building has proved to be powerful, and I think could even be more so, empowering patients to have an active role in their own care, sharing data across the population, and also improving access to care and coming up with models of care that might not require coming to clinic on a regular basis, but using remote monitoring and telemedicine and other such entities as ways to facilitate care, particularly for individuals who don't live so near to a large academic medical center. So just to conclude, NF1, it's a complex, variable, and multi-system disorder, lots of morbidity that people experience, some mortality, lots of things that have been sources of hope for the NF community. Patient advocacy groups single out the Children's Tumor Foundation that I've worked with for many years, which I think has really been a beacon in the NF population of hope for families. Lots of opportunities for funding. The NIH, the Department of Defense, which is, as I mentioned, funded the consortium and has had an NF research program for, well, since the early 90s. Children's Tumor Foundation and various private philanthropies have also been involved. I think since the kind of success with selumetinib, pharmaceutical companies have shown a real interest in NF1. Many of them have developed drugs that were sort of seeking answers in terms of particular tumors they could treat. The advantage to NF1 was the target was really very clear, and you can see the dramatic result that has occurred. It is a very collaborative research community who meet once a year at the NF conference, generally in June. I think 300 or 400 people. I think at once the European conference was over 800 people attended. It is a very kind of robust meeting with a lot of data sharing, including platforms that make that easier. And finally, there has been some success, but lots more remains to be done. So with that, let me just acknowledge lots of people. I won't name them individually, and I have named several of them as we've gone on. Many of my clinical collaborators, as well as individuals in the NF Clinical Trials Consortium, which includes 25 sites in the US and one in Australia. Michael Fisher is the chair of the steering committee. Various people in the lab, Ludwig Messiaen, who I mentioned, now retired. Yulong Fu has taken over that role, and many of my collaborators in the lab, and I've mentioned some of the funding sources, and there have been others that are shown here on this slide. And with that, I have, I think, a couple of minutes for questions, but thanks very much.
We have about 5 minutes for questions for Dr. Korff, if anyone would like to come up. Hi, Elaine.
Hi, Bruce. Really nice overview and great progress. One obvious question, I guess, with the selumetinib treatment that you talked about. So the clinical trials have established a maximum tolerable dose. For patients that do have a response, like the young boy that you showed, is there any value to thinking about once they've achieved some reasonable level of response, maybe a dose reduction to just sort of maybe manage some of the potential side effects, or has that not been looked at rigorously?
Well, though there have been efforts to look at what doses are required to sustain a response, and probably most of that has been driven by people who have had toxicities requiring dose reduction. And I can say sometimes that is possible to get away with, but other times it does lead to progression of the tumor. So I think most people feel pretty comfortable maintaining the dose at the recommended level at this point, recognizing the possibility of needing to reduce the dose if either cardiac toxicity, which would be one of the more common reasons, or skin toxicity occurs. I might add, by the way, that adults seem to be more sensitive to the adverse effects than children do for some reason. And that has also required some dose reductions. But whether we can get away with dose reduction in individuals on chronic treatment, that hasn't been looked at all that rigorously. The honest truth is, if you look at the person I showed you, his day-to-day life, it's changed in a way. Like, for example, you can't eat within 2 hours of the dose. And so your morning routine is completely altered, maybe forever. But on the other hand, he's kind of learned to deal with some of the relatively, for him, tolerable toxicities, and they're so afraid of seeing that tumor grow back. I think they're not interested in rocking the boat.
Yeah, thanks.
Thank you for a very comprehensive presentation. And I may have missed this, but what is the understanding of the biologic and/or physiologic mechanism for the clustering of the neurofibromas, given that they all have different second genetic hits?
Yeah, so you're referring, I guess, to the individual that had the cluster of cutaneous neurofibromas. I think the presumption would be this was an individual where all of those tumors shared a deletion, but that deletion was not visible in blood. And so I guess my assumption would be sometime in early development, a deletion occurred in some cell that was localized in general to the region where those tumors eventually erupted. And so that there's a sector of the body, in her case in the neck, that shares this deletion, whereas other places don't. And so it's probably a function, I would guess, of the timing in development when that deletion occurred and the kind of sector or region where those cells eventually wound up.
Thank you.
Just a question about the MEK inhibitors and how they work. So do they interrupt the signaling for the cells that move the components of the city? So, because from the graph you showed, the tumors recurred very quickly after the MEK inhibitors were blocked, so it sort of suggests that the underlying process continues in the background at the same rate, but you've just disrupted the signaling and then everything comes back as soon as that signaling is re-established. Is there actually any primary effect on the primary cells, or is it all a signaling block?
Well, I don't think it's known really exactly how this is working. I guess it's assumed that the Schwann cells that are completely lacking neurofibromin, and which can be demonstrated to have hyperactive RAS signaling, that signaling is now being turned off, and whatever it is that they're then sending into the environment that is recruiting all of these other cells must also no longer be active. And one reason why the tumors don't totally shrink could well be that there's lots of cells in there that are not dependent on RAS signaling for their sustenance, and they're just kind of bystanders. There's a fair amount of collagen and extracellular matrix, which is probably not going to go away even after whatever is actively promoting the growth of the tumors has ceased. So the assumption is that you're reducing the intercellular signaling ultimately that sustains the bulk of the tumor. But reality is I don't think we know precisely what's happening other than to presume that it's reducing RAS signaling. And also we don't know how important that is to those minus Schwann cells as opposed to whether the other cells in the environment, which are heterozygously mutated, may also have at least some degree of increase in RAS signaling. And they could too be targets, but I don't think that's been made clear at this point.
Thank you.
We have time for only one more question for Dr. Korff before we have to move on.
Bruce, outstanding presentation. Given that the clinical manifestations are, start to become apparent puberty and later, and that socially you can imagine this is really, really difficult when you start getting these neurofibromas for these adolescents or even adults. Is there any thought, given the success with the MEK inhibitors, about maybe some type of prophylactic intervention, maybe just before puberty and maybe at significantly lower doses, or is it estimated maybe that's just not worth it at this stage?
No, there actually is real interest in that. So there is a clinical trial in development that will ascertain children with plexiform neurofibromas that are small and have not yet grown to a point where they're causing significant morbidity, which ordinarily we would just watch and only treat if they grew to a certain point, to actually put some of them on MEK inhibitors early to see if we can prevent those tumors from ever growing to a point where they'll actually cause problems. As far as the cutaneous neurofibromas go, you know, it would make sense to look at the growth of cutaneous neurofibromas in settings where individuals have been on treatment. In a certain sense, that experiment is being done, although it's not being monitored as such, but I think it could be, and that is most of the people who are put on selumetinib for plexiforms are children, and at the time when they're treated, they usually don't have cutaneous neurofibromas. And on the assumption that they're going to be treated for a long period of time, it gives us a chance to see whether they will develop cutaneous neurofibromas at the same rate as other individuals comparable age who had not been treated. So although it's not a specifically intended experiment, it may turn out, because it's a very long-term kind of thing. We did try to do a clinical trial with selumetinib in adults with cutaneous neurofibromas. It ended up closing and didn't achieve its enrollment goals for a few reasons. One is it happened right during the kind of height of the COVID pandemic, so it was pretty hard to bring people in. But aside from that, it does have toxicity, and it includes skin toxicity, especially in adults. And so that, you know, they would come in with one skin problem and they were concerned that they would leave with another, and that wasn't necessarily a good selling point. Plus, many of them were daunted by the risk of cardiomyopathy and visual problems, which are not common, but, you know, it's one thing if you have airway compression and really a need for treatment of some sort. It's a different matter if you've been living your whole life with cutaneous tumors that you wish you didn't have, but how much risk you're willing to put yourself to avoid that is another matter. There actually is a ongoing trial that we're just about to join, looking at topical treatment with topical MEK inhibitors. And I guess, you know, it offers some alternative that's probably going to be a lot less toxic. On the other hand, if you're completely covered with tumors, it remains to be seen how practical that will be as a treatment. But, you know, it's an interesting, important question, and it wouldn't surprise me if we evolve to a point where really early prophylactic treatment is going to be the mainstay, but we have a lot of things to learn on that path.
Let's thank our keynote speaker, Dr. Korff.